respected chairpersons, senior members of the faculty and friends. Choosing the right NOAC for a clinical scenario involves a lot of clinical wisdom and a lot of knowledge about these drugs. As you know, the non-vitamin K antagonist oral anticoagulants or NOACs specifically inhibit the coagulation cascade at factor 2, that is dabigatran, or at factor 10, that is the rivaroxaban, apixaban or edoxaban. And this is the most common indication where we use oral anticoagulation. Atrial fibrillation with a CHADS VA, you must be knowing that the CHADS WASC score, the sex category has been taken off. So nowadays it is CHADS VA, score of 2 or more. NOACs are preferred over vitamin K antagonists in this subset to prevent ischemic stroke as per the latest guidelines. Only thing, we should use the correct dose. Dabigatran 150 mg twice daily, apixaban 5 mg twice daily, rivaroxaban 20 mg daily once, and edoxaban 60 mg once daily. We should not reduce the dose unless there are specific indications. This is our question. Are all NOACs the same in atrial fibrillation? There is no head-to-head comparison of NOACs. That is the problem. There have been trials with NOACs, each one individually, and this is being compared. So we cannot clearly say. But what these NOAC trials taught us was that they are as good as warfarin. Probably dabigatran 150 mg BD is superior to warfarin in preventing an ischemic stroke. They produce less major bleeding, except 150 mg BD dabigatran and rivaroxaban, where the bleeding is the same as warfarin. Well said and done, less intracranial bleeding. More GI bleed has been seen with dabigatran, rivaroxaban, edoxaban, so apixaban escapes this. Initial trials showed more ACS and MI with dabigatran. So these are the data that we have got from the trials. So how to choose your NOAC in an AF? If there is a high bleeding risk, probably a low dose dabigatran 110 mg or apixaban would be good. If there is a previous GI bleed, apixaban. High risk of ischemic stroke, low risk of bleed, something superior to warfarin, dabigatran 150 mg. Stroke on warfarin, dabigatran 150 BD. Coronary artery disease or ACS, rivaroxaban. Compliance problem, a once daily drug like rivaroxaban or edoxaban. We have to take into consideration the patient characteristics also. If the patient is elderly, above 80 years or some guidelines say 70, you have to use a lower dosage. We have to look at the renal function. If the creatinine clearance is more than 50, no issue. We can use the same dose. If it is less than 50 but more than 30, we have to reduce the dose. And if it is less than 30 up to 15, dabigatran cannot be used while the others can still be used. While if a patient is on hemodialysis, we have to go for vitamin K antagonists. One word about calculating creatinine clearance. Even though various methods are there, we are supposed to use the Cockcroft gold formula because this is the one that has been used in the trials, and you know how it is. 140 minus age into weight divided by 72 in the serum creatinine, and a correcting factor of 0.85 if it's a female. This is what the guidelines say. Use Cockcroft gold formula. One can use proton pump inhibitors, no effect on the dosage of NOACs. Rivaroxaban is preferably taken along with food. This is something that we have to advise to the patients. Others have no food-to-food interaction. When a patient is having stroke, we are going to give through a nasogastric tube. We have to crush the tablet. There is no issue except for dabigatran, because if you open a capsule of dabigatran, the bioavailability increases by 75%, so it's not advised. This is one area that all of us face and all of us have confusion. NOAC in a CAD patient with atrial fibrillation. Well, the choice is you can choose anyone, preferably rivaroxaban, because most of the trials in CAD and ACS have used rivaroxaban. the time window, the time period is the question. If it's an ACS undergoing PCI, the recommendation is for the first week you give triple therapy, oral anticoagulation with NOAC, P2Y12 inhibitor plus aspirin. From 1 week onwards, skip aspirin up to 12 months, and from 12 months onwards, only OAC. If it's a high risk PCI, lot of thrombus, lot of complicated PCI, you extend the triple therapy for 1 month, up to 1 year, continue OAC with P2Y12 inhibitor and then OAC alone. Chronic coronary syndrome undergoing PCI, first 1 week triple therapy, first 6 months double therapy. If it's a chronic coronary syndrome with high ischemic risk, again first 1 week OAC, up to 6 months OAC plus P2Y12 and then OAC alone. All the guidelines say it's better to combine clopidogrel with a NOAC rather than the other P2Y12 inhibitors. But very often we use lot of ticagrelor nowadays. There is limited data about its use with NOAC. One study that has been published in Thrombosis Update, which specifically looked at this pattern, showed increased bleeding risk. So still the choice is clopidogrel. If the patient is having LV clot, that is another indication for anticoagulation. NOACs can be used here for 3 to 6 months. Let us see some situations where NOACs cannot be used. One is moderate to severe mitral stenosis plus atrial fibrillation. This was because such patients were excluded from NOAC trial, so we had no data till 2022 when one trial called Invictus trial showed that VKA is superior to NOAC. But the guidelines say if you are unable to use warfarin or vitamin K antagonist, no monitoring, INR is not stable, you can use NOAC after informed consent in this group. There is one ongoing trial which may give the answer. Other valvular heart diseases with AF like mitral regurgitation, aortic stenosis, aortic regurgitation, one can use NOAC. They cannot be used in a mechanical valve. Actually, it is contraindicated because 2 trials, Realign and PROACT 2, have shown actually inferior results. Pregnancy and APLA syndrome are 2 situations where again they cannot be used. So far we were discussing atrial fibrillation. What about deep vein thrombosis? If the patient is having active cancer or pregnancy, better to go for low molecular weight heparins and vitamin K antagonists. If they have extremes of body weight, CKD or APLA, again vitamin K antagonists. Otherwise, NOACs score over VKA. Only thing, rivaroxaban and apixaban can be started straight away at a higher dose, rivaroxaban 30 mg instead of the 20, apixaban 20 mg instead of the 10. While dabigatran and edoxaban require initial parenteral anticoagulation for 5 days. So let us come back to our question. Choosing the right NOAC for a right clinical scenario. If the patient has got a high risk of bleeding, we use apixaban or dabigatran 110 mg. Previous GI bleeding or high risk of GI bleed, apixaban. High risk of ischemic stroke, a low bleeding risk, a higher dose of dabigatran can be used or rivaroxaban can be used. Previous stroke secondary prevention, rivaroxaban. Previous MI, ACS or risk of ACS or MI, rivaroxaban. Renal impairment, apixaban or rivaroxaban. GI upset disorders, apixaban. And patient preference, once daily dosage, lower cost may be the patient preference, and sometimes we often go to rivaroxaban. So, as I initially said, choosing the right NOAC in a clinical scenario involves a lot of clinical judgment as well as a little knowledge about the pharmacokinetics. One thing I have omitted is the use of concomitant drugs, because it's a long list where there is a lot of interaction with the NOACs, and we have to specifically look at that list and decide whether we have to change from one to the other. Thank you.